Imagine for a second that you find a lump in your breast.
Right.
For most people, the mind just immediately spirals. You instantly jump to the absolute worst case scenario. The statistics start flashing in your head, specifically that terrifying 1 in 8 chance of developing cancer.
Oh, absolutely. It feels like a ticking clock.
Exactly. But what if a medical textbook told you that, like, 90% of the time that lump isn't a disease at all, that it's just a harmless monthly hormonal weather system?
It's a huge perspective shift.
It really is. So today we are translating something incredibly dense. We're looking at excerpts from a comprehensive textbook chapter titled Comprehensive Management of Benign and Malignant Breast Disease by Jenny M. Wagner.
It's a fantastic, albeit very heavy source.
Yeah, heavy is the word.
Mm-hmm.
But our mission for this deep dive is to turn this into a real empowering toolkit just for you. We are going to demystify breast health, separate those harmless benign conditions from the malignant ones, and then
we get into the really amazing stuff.
Right. We're going to explore the incredibly personalized, honestly sci-fi level science of modern breast cancer treatment. So, okay, let's unpack this.
Let's do it.
Before we even touch on the scary world of cancer, we really have to look at how this text establishes a baseline for normal breast behavior, because we need to alleviate some immediate anxieties here.
We do. And according to the source, more than 90% of breast-related complaints and abnormalities that are evaluated in OBGYN practices are, well, they're entirely benign.
90%.
Yeah. The vast majority of the time a woman finds a lump or feels pain or notices a change, she's really just looking at the natural architecture of her own body responding to her environment. It's not a cancer diagnosis.
Which is such a massive relief to hear.
It is.
And the text highlights 2 really common benign culprits to explain what is actually happening in that 90%. We've got fibrocystic changes and fibroadenomas.
Right.
The way I like to think about fibrocystic changes is like a monthly hormonal weather system inside the breast.
That is a perfect analogy. And that weather system is entirely driven by ovarian hormones. Fibrocystic changes are essentially an exaggerated physiologic response, of the breast tissue to the natural ebb and flow of estrogen and progesterone during a menstrual cycle.
So it's just the tissue overreacting a bit.
Exactly. The tissue swells, it retains fluid, and it becomes nodular. This typically shows up in women between their 20s and 50s. And it naturally stops after menopause simply because the hormonal weather system powers down.
Unless, of course, a woman goes on hormone replacement therapy.
Right, exactly.
The physical symptoms described in the text are just so specific. It usually starts about a week before menstruation and subsides a week after. You get this dull, heavy pain, maybe radiating to the shoulders, and the physical examination reveals excessive nodularity. The text literally says it feels like peas.
Like a bag of peas, yeah.
But, I mean, if a woman feels a pea in her breast, how do doctors actually distinguish a harmless little fluid pocket from a solid mass that could be dangerous?
Well, the immediate clinical reflex is to use an ultrasound.
Okay.
The biological question the doctor is trying to answer is really simple. Is this mass fluid-filled or is it solid? If the ultrasound waves pass right through it, it's a simple fluid-filled cyst.
Which means it's safe.
Yeah, it can be easily drained or aspirated with a needle if it's bothering the patient. The text categorizes this as a non-proliferative lesion.
Meaning the cells aren't multiplying.
Exactly. They aren't multiplying rapidly or doing anything suspicious. That is vital information because non-proliferative lesions do not increase your risk for breast cancer down the line.
Okay, that's the fluid ones. But then there's the other common benign issue, fibroadenomas. And these are different from the cysts, right?
They are. A fibroadenoma is a solid mass. It's composed of glandular tissue, which are the parts of the breast that actually produce milk, and stromal tissue.
Which is like the biological scaffold.
Right, the structural connective tissue that holds everything in place. Fibroadenomas are actually the most common type of tumor seen in women in their 20s and 30s.
But they're still benign.
Yes, they are firm, non-tender, solitary masses. And unlike those fibrocystic changes, they do not shrink and swell with the menstrual cycle.
They just hang out.
Pretty much. They basically just stay there or grow very slowly and tend to only shrink after menopause when estrogen levels drop.
Okay, so again, finding a lump shouldn't trigger an immediate panic for you. Most of the time, it's just this natural architecture shifting around.
Absolutely.
But reading through the text, there's a crucial pivot point where benign starts inching toward malignant. And it centers around a term called atypical hyperplasia.
Yeah, that's the pivot.
Just the name sounds like cells behaving badly.
Because that is precisely what is happening under the microscope. Hyperplasia means the cells lining the milk ducts or the lobules are overgrowing. They are multiplying faster than they should.
In the atypical part.
The atypical part means that when a pathologist looks at these cells, they don't look like normal, healthy breast cells anymore. They've started to lose their uniform shape and structure. Yeah. Women diagnosed with atypical hyperplasias have a 4 to 5 times greater risk for developing breast cancer than women without these conditions.
4 to 5 times. Wow. That bridges us right into the overarching reality of this disease. The statistic that kind of hangs over women's health globally, 1 in 8 women in the U.S. will develop breast cancer.
The scope of it is staggering. In 2022 alone, there were an estimated 287,850 new invasive cases.
That's a huge number.
It is. And the text reveals a stark demographic reality within those numbers that highlights disparities in healthcare and biology. Non-Hispanic white women actually have the highest incidence of breast cancer.
Meaning they get it the most often.
Right. But Black women face the highest mortality rates, meaning they are more likely to die from the disease.
Man. But here's where it gets really interesting. Society kind of pushes this narrative that getting cancer is just pure bad luck. You just draw the short straw and boom, cancer.
Yeah, the lightning strike myth.
Exactly. But the textbook pushes back on that narrative hard. It describes breast cancer risk as a mosaic of statistical data points. It's not just random chance, it's a measurable map of biological exposures.
And that map is divided into non-modifiable risks and modifiable risks. The non-modifiable ones are the biological cards you were dealt.
Like genetics.
Right, carrying a genetic mutation like BRCA1 or BRCA2, having a strong family history, or simply the natural timeline of your reproductive life.
Wait, I want to stop on that reproductive timeline for a second, because the text specifically calls out menarche, your first period before age 12, and menopause after age 55 as major risk factors.
Yes, those are key data points.
I'm struggling to see how getting your period as an 11-year-old translates to a cancer diagnosis decades later. Is it like just about the total time the body is exposed to estrogen?
That is the exact mechanism at play. Estrogen is essentially the biological engine that drives cellular division in breast tissue. Every single menstrual cycle bathes the breast tissue in estrogen. So if you start your period very early or end it very late, you are adding years, sometimes dozens or hundreds of extra menstrual cycles of unopposed estrogen exposure to that tissue.
Oh, wow. So more exposure means more risk.
Right. More cellular division over a longer period means more opportunities for a genetic copying error to occur, which is how a cancer cell is born.
So estrogen is really the hidden engine here, which explains the modifiable risks, the things you actually have some control over.
Exactly.
The text lists weight gain after menopause, moderate to high alcohol consumption, physical inactivity, and the use of certain hormone replacement therapies. But wait, how does weight gain after menopause fit into this estrogen map? I thought ovaries stopped making estrogen then.
They do. But after menopause, a woman's primary source of estrogen isn't her ovaries. It actually comes from her fat tissue.
Wait, really? Fat tissue makes estrogen?
It does. Fat cells contain an enzyme called aromatase, which converts other hormones in the body into estrogen. So significant weight gain after menopause essentially creates a new manufacturing plant for estrogen.
Oh my God.
Yeah, it keeps that biological engine running and feeding the breast tissue when it should be powering down.
That is fascinating.
Yeah.
So if you're listening to this and mapping out your own timeline, your genetics, your age at first period, your lifestyle, the text introduces a tool you can actually ask your doctor about to measure all of this.
Yes, the Gale Model Risk Calculator.
Right. How does that work?
The Gale model is a highly validated clinical tool used to quantify this exact mosaic of risk. It takes tangible data points: a woman's current age, her age at her first period, her age at her first live birth.
Why the first live birth?
Because pregnancy permanently alters the cellular structure of the breast. It also looks at the number of first-degree relatives with breast cancer and any history of breast biopsies, especially those showing that atypical hyperplasia we talked about earlier.
And it puts all that together.
Yes, it synthesizes all of this to give a percentage risk for developing breast cancer in the next 5 years and over her entire lifetime.
And this isn't just to hand you a terrifying percentage and send you on your way, right?
Yeah.
It's to take action. Because if your risk is high, The text talks about shifting from passive waiting to active defense.
Exactly. They call it chemoprevention.
You could actually take drugs to stop the cancer before a single tumor even forms.
What's fascinating here is that we are talking about using powerful, targeted therapies protectively in completely healthy women. Guidelines suggest women at increased risk can be offered drugs like tamoxifen or raloxifene.
And these aren't just like daily vitamins.
No, not at all. They are selective estrogen receptor modulators. They actively block estrogen from interacting with the breast tissue, effectively starving any potential abnormal cells of the fuel they would need to multiply and become invasive cancers.
But obviously, despite our best efforts with screening and prevention, cancers do form.
Unfortunately, yes.
And when we cross that line into actual malignancy, the textbook details how these cellular invaders operate. It really breaks down the geography of the breast first, dividing it by where the cancer physically starts.
Right. Breast cancer is primarily classified by its origin point. About 80% of invasive carcinomas are ductal.
Meaning they start in the ducts.
Yes, the lactiferous ducts, which are the tiny biological pipes that carry milk to the nipple. Another 10 to 15% are lobular, originating in the lobules themselves, which are the glandular sacs where the milk is actually produced.
And it also matters if it's in situ versus invasive, right?
Crucially, yes.
Because in situ basically means the cancer is still contained inside the walls of that duct or lobule, like water inside a hose. Invasive means it is chewed through the wall of the hose and broken out into the surrounding breast tissue.
Where it can access blood vessels and lymph nodes.
Exactly. But knowing the physical location is just the foundation. Modern medicine requires us to know what is biologically feeding the tumor.
Right, the biomarkers. Yes. When a biopsy is taken, the pathologist will stain the cells to look for estrogen receptors, or ER, and progesterone receptors, or PR.
Okay, I want to use an analogy here because understanding these receptors is really the key to understanding the entire treatment plan.
Let's hear it.
Think of a cancer cell as a locked door. Inside that room is the machinery the cell needs to divide and conquer. But it needs a specific key to open the door and turn the machinery on. If a tumor is ER positive, it means it has estrogen locks on the outside of its cells.
That's right.
The body's natural circulating estrogen acts as the key, slides into that lock, and turns on the tumor's growth.
And what drugs like tamoxifen do is essentially shove a broken dummy key into that lock.
Oh, I love that.
Yeah, the tamoxifen molecule is structurally similar enough to estrogen that it fits into the estrogen receptor on the cancer cell, but it lacks the chemical ability to turn the cell on. It gets stuck in the lock, which blocks the real estrogen from getting in.
The text also heavily features aromatase inhibitors, like letrozole, for postmenopausal women. If tamoxifen jams the locks, aromatase inhibitors basically burn down the key factory, right?
That is exactly the mechanism. We mentioned earlier that after menopause, fat tissue uses the aromatase enzyme to manufacture estrogen. Right, the new factory. Aromatase inhibitors systematically block that enzyme across the entire body. They suppress plasma estrogen levels down to almost zero, ensuring that no keys are manufactured to feed the tumor at all.
Wow. But estrogen and progesterone aren't the only biomarkers. There is a third major player called HER2.
Yes, HER2.
The textbook says this specific protein is associated with a total loss of cell regulation. It makes the tumor highly aggressive.
HER2 stands for Human Epidermal Growth Factor Receptor 2. When a tumor overexpresses HER2, which happens in about 30% of all breast cancers, it has too many receptors on its surface telling the cell to grow and divide.
So it's like a car with a pedal stuck.
It's essentially a cell with its accelerator pedal stuck to the floor. And then there is the most challenging subtype, triple-negative breast cancer. This is a tumor that lacks estrogen receptors, lacks progesterone receptors, and does not overexpress HER2.
So it has no locks to jam and no accelerator pedal we can target.
Exactly. Because it lacks those specific biological targets, the incredibly effective hormonal therapies and HER2 blocking drugs simply bounce right off it.
Right, it means you have to use chemo.
Yes, it's a highly aggressive subtype that leaves oncologists with fewer targeted options, usually requiring them to rely heavily on traditional systemic chemotherapy to just blast all rapidly dividing cells in the body.
So what we're really learning from this text is that breast cancer isn't just one monolithic disease. It's a whole family of distinct genetic diseases that just happen to live in the same biological neighborhood.
That's the perfect way to phrase it.
And the text really drives this home with two specific genetic profile tests, Oncotype DX and mama print.
If we connect this to the bigger picture, these genetic tests represent a massive historical paradigm shift in oncology.
How so?
Well, 20 years ago, oncologists would look at the physical size of the tumor and whether it had reached the lymph nodes. If it was big or in the nodes, you got chemotherapy.
Right.
Today, for early-stage estrogen receptor-positive breast cancers, we don't just look at size. We take the tumor tissue itself, sequence its RNA, and look at the expression of 21 or 70 different genes.
And the Oncotype DX test synthesizes that genetic data and gives the patient a recurrence score.
It tells the oncologist the exact mathematical likelihood of that specific cancer returning within a decade. But more importantly, it acts as a predictive mechanism to answer the hardest question. Will this individual patient actually benefit from chemotherapy?
Oh, so they might not even need it.
Exactly. The genetic profiling might reveal that even though a tumor is relatively large, its genetic makeup is so sluggish and indolent that chemotherapy, which targets fast-growing cells, would offer absolutely zero benefit.
She might only need a pill to block estrogen. That is just incredible to think about. We're talking about sparing countless women from the severe toxicity, the hair loss, the nausea, and the immune suppression of chemotherapy, simply because we can read their specific tumor's genetic fingerprint.
It's the absolute definition of precision medicine. We are treating the unique biology of the tumor rather than blindly attacking its physical location.
And that precision extends directly from the pathology lab right into the operating room. The physical removal of the tumor has evolved so dramatically in recent years.
It really has.
The text walks through these modern surgical and reconstructive marvels. It used to be a one-size-fits-all radical mastectomy, right? Like removing the breast, the underlying chest muscle, everything.
Everything. But now the surgery is incredibly customized to the patient's anatomy and tumor biology. The evolution is profound.
So what's the standard now?
For early-stage cancers, the standard is often breast-conserving surgery, which most people know as a lumpectomy. The surgeon uses imaging to remove just the tumor and a tiny rim of healthy tissue around it to ensure clear margins.
Which preserves the physical breast.
Yes, and is typically followed by radiation to clean up any microscopic stray cells.
But sometimes a mastectomy is still medically necessary. If there are multiple tumors spread throughout the breast, or if the tumor is very large relative to the breast size, a lumpectomy just won't work.
That's right.
But even then, the textbook details how we've moved away from disfiguring surgeries to simple mastectomies, skin-sparing mastectomies, and even nipple-sparing mastectomies.
The skin-sparing and nipple-sparing techniques are true surgical marvels. The surgeon essentially hollows out the glandular breast tissue from the inside while leaving the outer envelope of the breast, the skin, and the nipple entirely intact.
That sounds incredibly complex.
It is, but it allows the reconstructive surgeon to use the patient's natural skin envelope, resulting in a much better, more natural cosmetic outcome.
But the surgical precision we are talking about isn't just focused on the breast itself, is it? It's heavily focused on the lymphatic system under the arm.
Crucially, yes. Because breast cancer cells love to migrate through the lymphatic system, it acts as a biological drainage highway for the body.
In the old days, surgeons would just blindly go into the armpit and scoop out all the axillary lymph nodes to see if the cancer had spread, right?
Yes, an axillary lymph node dissection.
But the text focuses heavily on a targeted procedure called a sentinel lymph node biopsy. How does that actually map the cancer's pathway?
Instead of removing all the nodes and hoping for the best, the surgeon injects a vital blue dye and a low-level radioactive tracer directly into the breast tissue surrounding the tumor.
Yeah.
That dye naturally follows the exact same anatomical drainage path that a rogue cancer cell would take. It flows through the lymphatic vessels and drains straight into the very first lymph node on that highway, the sentinel node.
So they just follow the dye.
Exactly. The surgeon makes a tiny incision in the armpit, follows the radioactive signal, finds that specific blue-stained node, and removes just that one to test for cancer.
And if that first blue node is clear of cancer, you can safely assume the rest of the highway is clear and leave the remaining nodes alone.
Yes, which is a huge deal, because removing all those nodes frequently causes lymphedema, this chronic, painful, irreversible swelling of the arm, because the lymphatic fluid can no longer drain properly.
Speaking of which, there is a massive nursing alert in this textbook regarding lymph node removal.
Yes, it is a non-negotiable, strict rule in patient care. If a woman has had an axillary lymph node dissection, healthcare workers must never take a blood pressure reading on that affected arm.
Never. No blood pressure cuffs, no IV lines, no blood draws on that side.
Never.
Because the lymphatic drainage is physically compromised, the tourniquet effect of a blood pressure cuffs can actually trigger severe permanent lymphedema. It's a critical safety protocol for you to know if you're ever advocating for a patient, a friend, or a family member.
It's so important.
Now, regarding reconstruction after a mastectomy, there are two main roads in the text. Implants, which are saline or silicone, versus flat procedures.
Flat procedures are incredible feats of microsurgery. A surgeon actually harvests tissue, fat, and blood vessels from the patient's own abdomen or back and transplants it to the chest to create a new breast composed entirely of autologous or self-donated tissue.
Wow. But implants are faster.
Yes. Implants offer a quicker, less invasive recovery, while flat procedures are much more complex but offer a permanent, natural-feeling result that ages with the patient.
So what does this all mean for the patient's timeline? Like, if someone have to go through the trauma of losing a breast, why wouldn't they always opt for simultaneous reconstruction? Just do it all in one long surgery so you wake up feeling whole.
It comes down to medical pragmatism and protecting the patient's long-term outcome. While simultaneous reconstruction is preferred when safe, the main limiting factor is radiation.
Ah, radiation.
Right? If the initial pathology report indicates that a patient will need post-mastectomy radiation to clear the chest wall, that radiation can severely damage, harden, or literally shrink a newly reconstructed breast, especially an implant.
Oh, that's terrible.
It is. In those cases, a delayed reconstruction is medically preferable to ensure the final cosmetic outcome isn't destroyed by the radiation beams.
Wow. It's such a complex physical and emotional calculus to navigate. We just talked about using aromatase inhibitors to starve the body of estrogen and radiation to burn away rogue cells.
Right.
But estrogen isn't just cancer fuel. It's what keeps a woman's bones strong and her heart healthy, which leads us to the brutal catch-22 of survivorship.
It's a very difficult phase.
The surgery is done, the chemo's finished, the tumor is gone, but the biological echoes of that treatment last for the rest of the patient's life.
And it is a massive growing population. There are over 3.8 million breast cancer survivors in the U.S. alone, and thanks to everything we've discussed, the 5-year survival rate is now 90%.
That's amazing. But surviving the cancer is really only the first hurdle. The very treatments that save the patient's life often induce severe chronic aging of the body.
The paradox here is just astounding. The text highlights several major survivorship issues, starting with cardiotoxicity.
Heart damage.
Yes. Certain foundational chemotherapy drugs, specifically a class called anthracyclines, as well as the HER2 targeted therapies, can cause significant progressive damage to the heart muscle. It weakens the heart's ability to pump blood.
So they need heart monitoring.
Yes, patients require ongoing echocardiograms and cardiac monitoring long after the cancer is technically cured. Then there's cancer-related fatigue, a profound, heavy exhaustion that doesn't resolve with a good night's sleep, and significant cognitive changes.
Chemo brain.
Right, where patients struggle with memory loss or difficulty concentrating.
And then there's the bone damage, the osteoporosis. Because if you have an estrogen-positive tumor, you are put on those anti-estrogen therapies to starve the cancer. But your skeletal system desperately needs estrogen to maintain bone density.
This raises an important question about how we manage quality of life. The treatments often plunge women into abrupt premature menopause, triggering severe hot flashes, sleep deprivation, vaginal dryness, and rapid bone loss.
And for a healthy woman going through natural menopause, a doctor would just readily prescribe hormone replacement therapy, HRT, to replace that lost estrogen and ease those severe symptoms.
Exactly. But for a breast cancer survivor, HRT is strictly contraindicated.
Because giving her a pill containing estrogen to fix her hot flashes could literally act as the key that unlocks a dormant microscopic cancer cell and causes a massive recurrence. She just has to endure the symptoms.
It is a brutal catch-22. This is why the text stresses that survivorship care must be highly tailored based on age.
How so?
Well, for young women, survivorship often revolves around sudden treatment-induced loss of fertility and grieving the developmental milestones they are missing. For older women, it's about managing these new toxicities alongside existing conditions, requiring comprehensive geriatric assessments rather than just applying a standard age-based protocol.
If you or a loved one are navigating survivorship, this text makes one thing abundantly clear. You must advocate for comprehensive post-care. You can't just go in for a mammogram and check for cancer recurrence.
No, you need much more.
You need DEXA scans every 2 years to monitor your bone density. You need regular cardiac monitoring if you received anthracyclines. You are managing a completely new baseline of health.
Survivorship is an active, vigilant state, not a passive one. It requires an interprofessional healthcare team to continuously manage the chronic sequelae of the exact treatments that save the patient's life.
We have covered so much vital ground today. We started with the immense reassurance that over 90% of breast lumps are just benign changes, hormonal weather systems, or simple fibroadenomas. We mapped the statistical reality of risk, highlighting that cumulative exposure to estrogen is often the silent engine driving cellular changes.
We examine the incredibly personalized nature of modern treatment, diving into the biology of tumor receptors and how genetic profiling like Oncotype DX tells us exactly how a tumor behaves.
Sparing so many women from unnecessary toxic chemotherapy.
Exactly. And we explored the surgical precision that aims to conserve tissue and map the lymphatic system to prevent lifelong complications.
And finally, we look at the hard-won, lifelong reality of survivorship. The profound paradox of life-saving drugs leaving a permanent mark on the heart and bones. It is a brilliant, dense text, and I want to leave you with one final thought to mull over.
We discussed how advanced tests like MammaPrint and Oncotype DX look at the specific genetic fingerprint of a tumor to dictate the entire treatment plan.
Exactly. So given these incredible advancements in genetic profiling, we are clearly entering an era where treating cancer is becoming less about the physical location of the tumor and entirely about its unique genetic mutations.
Right.
So here's the question for you. Will there be a day in the near future when we no longer classify cancers by the organ they started in, like saying breast cancer or lung cancer, but entirely by the specific genetic mutations that drive them? Will we just call it a HER2-driven disease, regardless of where it lives in the body? Keep questioning, keep exploring, and stay curious.